Christy. Welcome to our call. If you have questions during the call, you can type them in the chat box and we'll address them at the end of the call. And we're really appreciative and thankful that you're with us today. And if you have any questions, you can address them to me as one of the co-hosts in the chat box. At this time, I'm going to turn the time over to Christa Sakowski, our clinical lead, and to Elliott Main, our medical director. Go ahead, Christa.
Hi, my name is Christa Sakowski. I'm one of the clinical leads for CMQCC. Elliott and I will be moderating this panel discussion today. We're going to go through welcome and introduction of all the panelists. I'm going to ask the panelists when I say your first name to just go ahead and give a little introduction of yourself, where you're from, and what your role is. We'll go through the moderated discussion questions with Elliott and myself. And then at the end of the call, Ann Castles will be reviewing using the Maternal Data Center to engage your providers, and then we'll do some Q&A at the end. So let's go ahead and start with Gail.
Hello, I'm Gail Full. I've been a labor and delivery nurse for about 30 years. I've been at San Ramon, and I've functioned in the Director of Family Birthing role for the last 15 years.
Janelle?
Hi, I'm Janelle Leedy, Labor and Delivery Manager at Clovis Community. I've been with Clovis for 10 years.
Allie?
Hi, I'm Allie. I am the Labor and Delivery Educator for Clovis Community, and I've been a nurse here for almost 11 years.
Hi, and I'm Dr. Reddington. I am currently functioning in the lead role of department chair here, which I've held for the last 4 years. And I have actually practiced at Clovis for approximately 25 years.
Dorinda?
Hi, I'm Dorinda Hawk. I'm from Anaheim Global. I'm the Director of Mom and Baby. I've been a Director of Mom and Baby, Labor and Delivery, Perinatal Services, Postpartum Nursery, and NICU for over the last 10 years. And Dr. Ahad is just finishing surgery and he'll be joining us shortly, but he's the OBGYN here at Anaheim Global.
Great.
Yes, I'm here.
Yay! The purposes of this webinar today is to talk about engaging our physicians in QI work. And the reason that this panel was selected is because they really demonstrated a strong ability to pull in their physician champion and beyond that really impact their QI work. So we're hoping to share these tips and tricks with you that San Ramon, Clovis, and Anaheim have developed and see if you can incorporate them in your own facilities.
And this is Elliott Main, the Medical Director of CMQCC. I'd just like to thank our panelists today and note that they represent between 100 and 200 years of experience on labor and delivery. And not to indicate that this says anything about their age, but their experience is wide and vast, and we want to draw upon that today. And they've all been very enthusiastic participants in these projects, and we want to be able to bottle that enthusiasm and to help share it around the state as we go forward. So the way we're organizing this is that we're going to ask our panel a set of questions, and we really want to draw out everybody's experiences on this, and we'll go forward. So Christa, why don't you start?
Sure. So this question is for the whole group, physicians and nursing. What did you see as the biggest barrier to engaging a physician champion at your facility?
This is Gail, and I'll go ahead and get started here. One of the biggest challenges, barriers we had is we have between 5 and 7 practicing obstetricians. They're all independent practitioners. It's not groups. And so to ask someone to be the champion is cutting into their office life, their personal life, their practice life. It changes things. So that was a very big part of it for us.
How did you overcome it?
Well, we ended up using the least common denominator, the person at the top. Dr. Matthews was chosen, and she was our chief at the time. I think what was good is she was a new chief, so she didn't kind of have preconceived ideas. She came in and was willing to take a look at something new. So I think that was a benefit for us. Also, she fit in with the middle of the group. It wasn't like her numbers were the best or, you know, she succeeded in this. She was someone that also had to make changes. So in a way, I think that lended credence to her because she was in with the rest of them. They were all in the same boat, so to speak.
Mm-hmm.
Other barriers?
Go ahead, Christa. I'm not sure that they heard you.
Any other barriers from any of the other hospitals? I know there had to be a lot because people have a lot of trouble getting physician champions. So.
Well, I think there's a, you know, it's a Gail again because nobody else is talking, so I'm okay with it. I think it's hard for a physician to impose on their peers, their colleagues, a new way to do things. It may not be something they've done or been successful with. So I think, you know, on a personal level, why would someone pick up something that's kind of new and different and, gee, will I be successful? I think that that is a part of it as well.
This is Dorinda Hawk.
Go ahead, please.
Sorry, I was just going to contribute. I think for us, it's hard. Our physicians are very busy. They're private practice here, so they're trying to balance their schedule and the unpredictability of labor and delivery or obstetrics. But what I found helpful so my biggest barrier was the physician's time. And Dr. Hott is great as far as communicating through. I can send him things in email and text, and we're able to kind of communicate back and forth at his convenience, so that he is able to look over some algorithm we put together or an idea we have. So kind of to best use his time rather than just inundating him with policies or reading research. It's just kind of what we could put together that was easy, quick to digest, and then get his feedback and kind of work that way. So working flexible through their schedule.
I think that's a really important point because in almost all of our hospitals, everyone is in a private practice environment. There's a few hospitals that have medical directors, but that's a minority, where the hospital will actually pay people to lead quality improvement projects. We encourage that, but that isn't as widespread. So I think the strategies you outlined are really important, where you distill the information and work with the physician's own schedule as much as possible.
This is Allie from Clovis. I think also, you know, getting them to see the buy-in on it. Is it something that they're passionate about? Do they feel like it's something that needs to be changed? Or, you know, is it a physician that doesn't see an issue with it? And so really looking at the physician that, you know, believes in the cause and the care that you're trying to do and what you're trying to, you know, better, really can help to navigate through that and find that physician to be able to approach them, knowing that there's someone that does have passion for that topic or things like that. And then doing your best to adjust to their time schedule and, you know, really making it work for them, you know, to be mindful of that. Because we all have, you know, work-life balance to meet as well.
So that's a great segue to our next question about why you picked a particular physician that you approached. Passion is certainly something that you can't do without, whether it's working at the state level or working at your hospital level. or working with individual patients for that matter, what other characteristics did you look for besides passion? And this would be to the nurses or to anybody on the panel.
I think we also look for someone that engages well with the nurses and other physicians, somebody that's well-rounded, who has a good relationship with both parties, knowing that that is going to be how you kind of cement everybody on the same page and getting everybody on board. You know, it makes a difference when it's someone that's respected and, you know, by everybody, and not, you know, someone that we're not seeing all the time, or a physician that isn't, you know, there and present on the unit.
This is Dr. Ahad, if you don't mind me to
Please
interfere. Dr. Ahad from Anaheim Global.
Please comment.
Okay, I believe the main things between the nurses and the doctors are the communications. If you have good communications with the nurses and the doctors on the same page, as well as like easy access to this physician, let's say well-respected physician with easy access for this physician, plus easy communications. This trio, I think, is the main things to make everything get easier and get everything done appropriately and faster.
Yeah, and this is Dorinda Hawk from Anaheim. And with selecting Dr. Ahad, it was a pretty easy decision because he's a physician who is up to date on evidence-based practice. He's not the fuddy-duddy who you have to kind of pull along with changes in obstetrics. So he stays very abreast of what's going on, committee opinions that are out there. He brings the education to his peers. So he's a good candidate because they already see him as a resource. So he was kind of the ideal person for us to select because he's credible amongst his peers and he's stays kind of most up to date with what's going on.
So that's a great segue to the next question, which is what recruitment strategies did you try? So how did you present it to your physician as part of the NTSC collaborative? Did something fail? And then what was the aha that made your physician say, okay, maybe, I can make time to partner with you on this?
This is Laura Reddington from Clovis Community. And I have to say that at our hospital, our C-section rate was probably consistently above 30%. And so as department chair, we'd actually been looking at this from a quality standpoint. So Elliott talked about passion, and I guess I do have passion for my job, but I also have passion for providing the very best care possible. So I think that I personally had started to look at what is the best care possible for patients. And if it's not doing elective C-sections, then I need to figure out how to do better vaginal deliveries and make my vaginal deliveries more optimal and my outcomes more optimal. And so I think when we decided to join the collaborative as with this group, for me, it was an easy decision to want to move forward as being the physician champion. And I just want to reiterate that sometimes what one person wants to do, you can't be accomplished. You have to understand that it really has to be a team approach. And so I'd like to emphasize the relationship between the other physicians and the nurses and the whole team, that's what makes the best quality outcome for the patients. And I think that's what I was looking for when I became the physician champion at Clovis.
I hear a little bit more from the nursing leaders about how you approached your physician? Because I think that that's something that people that are having a hard time getting a physician champion would like to hear. Like, what did you do or say to approach your physician in joining you on this project or other QI projects?
So this is Gail at San Ramon, and what we did, I actually, my CNO, who actually was new at the time, so I had the CNO and myself met with the physician over lunch, and we were discussing not just this, but where we wanted to see the OB department go in the next couple of years while she was going to be chief. And so it was a good time to discuss the opportunity, and that we would have the support of CMQCC, and it wasn't going to be, we would be on our own. And, you know, certainly there were some meetings we had to attend, but we assured her, you know, we would work as a team, have things prepared ahead of time so she could review it, so that it would impact her personal life the least, as the others did. But also that she's coming in with fresh eyes and a fresh perspective, and we use that avenue as well. And I think it was very good to have someone that was in the trenches with them, feels their pain, and yet still has that desire to provide an improved experience for the patient.
This is Dorinda Hawk from Anaheim Global. What worked for me was actually I printed up the blinded and unblinded data for each provider at our hospital with regards to primary C-sections and TSV rates. And I provided that to the doctor who had his aha moment of reading his own data and then saying, well, we can do better than this. And so it was sort of a backwards way, I guess, of going about it. But when he saw the data and then said, I think we can as well, are you interested in sort of being the champion? That's kind of how I approached it, which was great because the first medical staff meeting following that, when the data was passed to each provider, he was able to get on his soapbox and say, look, we can't, as obstetricians, be okay with our rates being as they are. If you're impressed with your information here, well then good. You won't have a lot to do in the beginning. But if you're like me and looking at this thinking how we can do better, well then I think I need your help. He sort of pleaded with the panel and approached it that way.
That's great. I love hearing that. That's a great strategy, both hospitals. Wonderful. Elliott?
So what, as the physicians on the call, what made you decide to take on the role? I think Laura has talked about a passion, and both Dr. Ahmad too, the passion to do better. Were there other aspects of it that really attracted you to take this job, thinking about how you could model this for others on the call, in particularly generalizable comments?
I'd like to bring up a picture that we have going on in our sister hospital of where they're doing more and more surgeries for accretas, percretas, incretas, and just outcomes that are not good outcomes and complications that are coming from patients having gone through previous surgery. And sometimes even when we have a good outcome after a cesarean section, we take it for granted that we're always going to have that perfect outcome. And looking at some of the newer data that's coming out and the complications that are happening after only one C-section, I think for me was kind of mind-boggling. I don't want to be the person that has the complication and has a bad outcome. So I've kind of had to review my own goals and my own data and try to look forward to where do I want to see my patients in 10 years. If they want to have 4 or 5 children, I don't want them to be having to decide whether it's safe or not to have another cesarean section. And so for me, it was wanting to look at my own data, but then wanting to pass that on to others and see if I can convince some of the other physicians that I work with closely that have higher C-section rates. I want them to say, yeah, we need to look at this closely and evaluate it. And I'm hoping to get everyone on the same page, which is not always easy, but that's what we're trying to get others to adopt the same strategies.
So a lot of teams have been able to identify a physician, a lot of hospitals have been able to identify a physician champion, but there's a difference between having a champion in name and a champion that's truly engaged in the process. So is there some point in the project where you kind of made a switch or felt the difference to really become engaged and you felt part of the whole collaborative team? As versus saying, okay, I'll take on this role and I'll see what I can do. Was there something that happened where you really felt that team feeling between your whole nursing staff and physician group?
I think having maybe one win might do it. We had one day where the entire board was primate. Historically, half of them would have been C-sections. You know, we were running about a 38%. So it was nice to have, you know, 8 patients up there and all 8 of them were vag delivery. So I think that was the first success. In, like, you know, we've been using the peanut balls. We've been talking about it. The OBs are talking about it. They got their data unblinded. So we had done all these things, but until you had that day when there was no C-sections on the board, that for us was the win, the aha moment of, you know what, we can do this. We can turn it around.
At Anaheim, we had a similar experience where we had 6 primates on the board, 2 different OB doctors, and one doctor had the nurses pushing with this patient 3 hours, and he was going into a second patient who had been pushing for 2 hours. And he said, my gosh, these nurses will virtually stand on their heads now to get these first-time moms to deliver vaginally. And I looked at him, I said, I know, isn't it fantastic? And the next day then we had a candy bar labeled the cat's meow, and the CEO gave it to him because his 3 patients all delivered vaginally. And that was sort of the biggest change in our hospital, was because he was the low performer, the one who would give in the easiest, the most resistant to change, I should say. And when he had that and then was acknowledged for going above or beyond to make it happen, you could see him engaged in the process much differently than he had been up until that point. And then the physicians started amongst each other saying, well, next month I want to get the highest NTSV patients, and I want that every single month. So it sort of started a healthy competition between each other, which was funny. And if anytime they caught each other on the unit passing each other, they would ask, what's your rates this month? What's your rate? So they began to hold each other accountable and have a little fun with it as well.
There is a real power to rewards, even as simple as a candy bar or a pat on the back. Human psychology really does want those kinds of rewards. And whether it's at the nursing level and giving people, and some of our hospitals have done a star for every NTSV delivery that they can achieve, to physician awards, to even hospital level rewards. So in the next 10 days, the Secretary of State, Secretary of Health and Human Services for California, will be sharing awards for all the hospitals that are now below 23.9%, and it's almost 60% of the hospitals in California. That's how much it's changed from the last 3 years. It used to be in the 30%, and now it's 60% of the hospitals are below. So awards are actually very, very effective. So thank you for sharing that.
Oh, this is Janelle from Clovis. I think the biggest change that happened here at Clovis was just identifying those patients and changing and identifying the NTSVs on our grease board and changing the color. And it was kind of a nuisance at first, but it did create a lot of dialogue with the nurses and physicians. And I think just identifying that opportunity that we had there was the biggest turning point for us. I think everyone identifying those patients and giving them longer to labor. I know Dr. Reddington can probably agree that the physicians, there was a lot of dialogue when we made that change.
Well, and early on, this scale again, early on we had some growth with the coding department because we had found that we had many items that were missing that actually would have pulled these patients out. So getting the coding set also improved, and then it does take some of that pressure off of just the provider, like it's all them, because it's a multitude of issues. It's not just one issue, and that was also a good thing that happened.
So what impact did you see on your process once the physician became engaged? But it sounds like a lot of your physicians were engaged pretty early. I don't know if this is something you can comment on, but what do you see as the impact of physician engagement? Can you do it without them? For example, and how has it helped your process, having the physician strongly engaged?
I think for us here at Clovis, we definitely, Dr. Reddington was definitely engaged from the beginning. But for us, it was looking at, how do we get them delivered vaginally more often, and what does that look like? And we had actually gone and have looked at cervical ripening and have implemented a policy that includes the fully bulb cervical ripening along with meso, and now have seen it tenfold from, once every 6 months. So it's definitely become more common for us, and Dr. Reddington has begun challenging our other physicians to try it, see if it works, just to kind of give them something new, something different than just Cervidil, or, really looking at how do I get them to where they need to be if I'm gonna, have to induce them. How do I still, get them a vaginal delivery when their chances are a lot higher in that sense? So we really looked at the process of induction and cervical ripening and really defining, all of those terms and what different processes we can do that we don't do now, not sticking with the same thing that's not working. So really, kind of pushing the envelope to see, there's other things out there that are working for people. How do we get that here? And how do we get physicians, to buy into it? So I think that's been really successful for us so far. So we're still plucking and trying to get more on board, which has been really good.
And I have to jump in here, having been on the calls with you monthly, in that Dr. Reddington has really kind of gone, okay, I'm going to learn this, I'm going to do it, and I'm going to model it, and I'm going to share it. And it's just a huge part of being the physician champion versus, I come to the meetings, what is it that you are trying to accomplish? I'll do my best. So she's really championed this process at Clovis of really modeling it and talking about it again. And I think it's been hugely impactful, and definitely the role of physician champion.
And I'd like to add one other thing. It's Dr. Reddington again. Allie was talking about, we've discussed the cervical ripening, and I think we've come up with better definitions. And I think that having, again, everybody communicating on the same page, not just the nurses or not just the physicians, but everybody being engaged in what is the correct terminology and what is a definition of failure to progress or arrest of labor. I think that was kind of gray before, and I think it's become more defined. And I think some of the nurses are actually saying to the physicians, well, we haven't tried this or we haven't tried this. And since we're educating people more now about the process of actual labor and what it means and what it is, I think that's made a huge difference for our facility also.
So I think those are two incredibly important points. One is being a role model, and the other is someone who can promote communications among the staff, because labor is nothing if it's not a team effort. It involves nursing as much as, if not more than physicians, and so you have to be able to include them and be able to share ideas back and forth about what to do next. So those are great points. Other keys here for the physician leadership? Okay.
So how do you feel about this relationship that you've built with your physician champions? Do you see this, ending with the end of the collaborative, choosing new projects to work on either within NTSV or outside of NTSV, quality projects on your unit? Have you been able to feel the change of the sense and empowerment that it gives you to be working with a physician champion versus trying to accomplish the QI things without them?
This is Dorinda. I think if we don't keep the momentum going and work on other projects, the physicians will be longing for something because they've had such great involvement and engagement in the process from the beginning that they'll be looking for, okay, we've improved this, what can we work on next? It leaves them hungry. So I would imagine that we move on to another initiative and sustain kind of where we're at with this one.
Here at Clovis, it's taken us so long to achieve our goal, and we met it for 2 months straight, and then we did see it go up again the last reported month. I think in order to maintain the change, we're going to have to keep working on this quality measure. We are working on others as well, but this one is so important. I don't see it ending at the end of the collaborative.
Mm-hmm. I think where we were looking at, though, is the fact that once you develop a good relationship on a QI project, it's going to spin off to other projects and really create that environment that we're looking for on labor and delivery, which is nurses and physicians working together for the improvement of care for all. And it's the snowballing effect. There were several examples today of once you have a success, you get more successes, and I think that's the power of the teamwork that we're talking about. So, what advice would you give teams looking to engage a physician champion for others? We've talked about some, but are there other points that you'd like to make about how do you engage someone who's everybody's busy in their offices, everybody has got lots of things to do. What would be your words of advice?
This is Gail at San Ramon. I know it's not exactly the question you asked, but I would like to say that one of the things that helped all of the physicians feel a part of things was that unblinding of the data. Originally, when they went to the group and asked them to unblind the data, all but one said yes. So it's pretty funny when you have 8 of them yes, 1 no, and so everybody knows who the no is, right? So the data came out anyway. And then once that was like almost it evened the playing field. Even the people that were doing well, maybe it sparked a conversation between 2 office partners. One of them was in single digits and one of them was in double digits. So I think it brought them closer because all their warts and whatever were showing, and nobody was feeling holier than thou or better than this or whatever. I think it really made it so that they were able to talk about it. Whereas before it was like a no, we didn't talk about it.
I think here at our facility, you see it, the discrepancy of engagement between different chairs and medical directors. So I think someone with a proven history of following through with medical staff, I think that would probably be the one with the biggest influence and that one you would want to grab. There is work to be done. You have to be committed and committed to engaging the nursing staff and medical staff. So that's not always easy. So I see that as one of the biggest challenges. And also, like Ellie had said before, someone that works really well and collaboratively with nurses and physicians and respected by both.
I'd also like to hear physicians engaging other physicians. If there was any tips that the physicians on the call can share about engaging the other physicians other than showing the data.
This is Laura Reddington. For me, I think it's got to be an education because my physicians are smart. My physicians are good doctors. But for me, I'm seeing if there's going to be a reason to change, I need to provide the education of why it's important to change. And we're still coming across some of the patients in our region saying that they want to have, you know, an elective cesarean section. And so it's not only educating my physicians, we're starting to try and learn how to better educate the patients also what the outcomes might be if they choose that. And so I guess I come back to education at the forefront or foundation for me of what I use as a technique to offer change and why you should change.
So this is Elliott. I was chairman of a very large department with 100 OBGYNs for a good number of years. And one of the techniques I used quite effectively was each year we would go over all of our data and hand out unblinded our C-section rates. But then I would ask the two obstetricians who had the lowest rates to get up in front of the department and talk about what their strategies were. So they were essentially highlighted, rewarded for theirs, but they could share what they had done because so people heard from their peers, you know, and they could identify with this physician who had maybe a NTSV rate of 10 or 15%, whereas others were much higher, as to what they did in their very own hospital, same hospital, to achieve such a rate. And that's a nice way of both awarding and getting some peer support for it. And I'd like to build on Laura's point about patient education, because I think that's an opportunity. I was going to mention earlier, when people were talking about patient voices, there's a big series on USA Today on maternal mortality, but the one I'd like to, if you Google that, there's a section on near misses, and there's 4 or 5 women who have short videos, 1.5 minutes, 2 minutes, so they're quite usable, that talk about placenta accreta. And none of them had ever heard of any risks from the C-sections. I think those are powerful to use both in the department meetings and for educating patients potentially. So USA Today, and just Google maternal mortality, and you go through to the patient video section.
And this is Christa, and after several rounds of the collaborative, I think another key way to find a physician champion when you don't have one, or you don't have somebody that keeps abreast of all the current research, or somebody that maybe doesn't have a great relationship, or you feel like you have nobody, sometimes the best way to go about that is to select champions of specific parts of the project. So maybe somebody doesn't feel that they have enough time to invest, or they're not passionate enough to invest in being the physician champion of the whole QI project, but maybe there's a piece they can champion. You know, somebody that already has a lower C-section rate, maybe there's a practice that they have that they can champion, or somebody that wants to take on fully bold induction, maybe that they can just champion that practice, as opposed to being the physician that just talks about rates. I mean, obviously it's more powerful to have somebody that encompasses all the pieces of being a physician champion, but having someone on your team is better than having no one on your team from the physician world. And in addition to that, sometimes those physicians that say they're just going to take on a piece, or okay, maybe I can talk about Foley bulb induction, whatever it is, they wind up taking more and becoming more like a project. So I would say that it doesn't have to be an all or nothing. If you have no ideal person, it's still important to try to reach out to our physician partners, because it does make the work more powerful and easier for everybody, and ultimately better for the patient.
So I like Christa's comment a lot. And even if you are the physician champion, it's wonderful for you to engage other folks to be champions on the Foley bulbs, on induction, or on second stage labor management, or whatever subtopics. So the more champions, the better, because then you obviously spread the gospel. Okay.
Go ahead.
Go ahead. No.
Are you going to turn it over to Anne, or do you have something else?
No, go ahead. Turn it over to Anne.
So we're going to go ahead and turn over the rest of the presentation to Anne, so we can look at our MDC a little bit and our provider level statistics to help you engage your physicians. We will be doing a Q&A at the end, encompassing the panel discussion as well as the MDC presentation.
Hi, everybody. This is Ann Castles, and I'm the Associate Director of the CMQCC Maternal Data Center. And I think what we've already heard today several times is often there's no better way to engage your larger physician team than sharing their performance metrics with them. Because worst case, feeding physicians back their own results tends to be a very effective attention getter. And best case, it is that aha moment that, that we talked about on this phone call. So for those of you that are at hospitals that do participate in the CMQCC Maternal Data Center, I'm going to take about 10 minutes to show you how to generate the provider level metrics in the MDC. Now do note, I know there might be some folks here that are outside of California or Washington or Oregon where we operate the Maternal Data Center. The Maternal Data Center is a confidential tool for participating hospitals, and access is only available to those folks that have specifically been invited by the MDC admin at their hospital. There are a couple of different paths to seeing the provider metrics in the Maternal Data Center. I'm going to show you the path today through our main provider section. So if you are an authorized MDC user, once you log into your hospital's homepage, and we're going to be using Demo Hospital today, but once you log into your hospital's homepage, you will be able to go directly to the provider section. It's going to be in the lower left corner of your home page. You just click on that header that says Provider Performance Measures, and this will take you to the All Providers report that shows a list of all of your providers that have performed deliveries at your hospital in the last 12 months, along with a set of metrics for each of those providers. Now notice the tabs up here at the top. There's a tab for cesarean metrics, for elective delivery metrics, for vaginal delivery metrics. Each of these tabs has a different set of measures under them. So the default is going to be the cesarean metric tab, where you see the results for your providers, and will list an overall C-section rate, a primary C-section rate, NTSV C-section rate, and so on. If we were to click on to the vaginal delivery metric tab, then we'd see a different set of metrics. So here's where we'd see lacerations, operative vaginal delivery rates, and episiotomies. So just be aware that these tabs will open up doors to additional metrics for you. So hospitals often ask us for our recommendation on how to share the results with their providers. And we've already heard from a couple of folks on this call today of what they've done. For us, one of the first steps we would recommend is that you take some time to review your results with a smaller group of your leadership team in L&D to ensure that the results have some face space validity, and there are no major gaps. So for example, if you're a California hospital, we're receiving the data on the delivering provider from the birth certificate data. And these data have been shown to be highly accurate in terms of who actually delivered the baby, but we do see some typos in license numbers sometimes. Now, the good news is the Maternal Data Center has developed a tool to make it very easy to clean up these typo issues. So once you're on your main provider screen, if you see a yellow alert that looks like this, since X date, 37 providers could not be matched to a name, click here. We're going to take you to a place where you can really, really easily clean up those license number issues. We're not going to walk through it today, but if anybody has any questions about it, the MDC team is happy to work with you one-on-one to walk you through how to use that remapping tool. In terms of starting to share the results of these metrics with your providers, so one approach is a graduated sharing strategy. So this is a three-stage approach in which you might start off sharing individual provider reports confidentially, then move to sharing comparative data blinded, and then move to unblinding the comparative data. So let's walk through how to generate each of these different types of reports in the Maternal Data Center. Okay. So the first is, how do you generate an individual provider report? So again, right from this all provider screen, you're going to see your list of providers, and you just click on one of their names. And that will take you to a report specific to Dr. John Kerner at your hospital, where you will see 12 different clinical quality metrics for that provider, the provider's rates compared to the hospital's rates, compared to the statewide rates. And then this last column can be very useful. It's the provider's contribution to the overall hospital rate. And this column can help folks see to what extent the provider might be an outlier compared to other providers. If you do choose to share these reports confidentially, you can very easily print them out. There is a print button right here, right on the screen. Or conversely, if you were back on the All Providers Report screen, then there is a button that says Print Individual Reports. And with one click, you can generate a PDF file that includes all of the individual provider reports in that one click. And then you can choose how you want to distribute them to your providers. Now, step 2 in a graduated strategy might be starting to share the comparative data for your full set of providers, but in a blinded way. And once again, the Maternal Data Center makes it very easy to blind these data. You will notice that there's a drop-down menu near the upper right corner of the screen, and this is where you can toggle between seeing providers by full name, by license number, or blinded. So you can just use that drop-down menu, choose blinded. It will automatically blind the provider name. So we can see down here, then Drs. Kerner and Danny Dan have switched to randomly generated numbers that represent them. And then if you are a hospital admin in the Maternal Data Center or a data entry user, you will have access to this masking crosswalk, which is really just an Excel spreadsheet that maps each provider name to the license number and to that blinded ID. So you will know who is who on this list. And then you can choose to, some hospitals will post this comparative data in a staff lounge. Some of them might be sharing it at committee meetings. So you can choose how you want to present these comparative data. And then lastly, if you choose, then you can go back. Stage 3 would be moving back to showing the data by full name. And once again, you can just toggle back to full name and you would be able to print these data out and you can also download them into an Excel spreadsheet using this Download CSV button. Now, notice that by default, the Maternal Data Center is going to show you the provider level metrics for the most recent 12-month period. Okay. And we do this because generally a year is going to generate pretty robust metrics for that 12-month period for those providers that deliver regularly at your hospital. That said, if you'd like to, you can change the reporting period by using these drop-down menus for start date and duration to basically represent any period of time you wish. So you could choose starting from January 1, 2018, and at this point in time, you could go through, most of you have submitted your August 2018 data. You could choose a duration of 8 months to have year-to-date numbers for your providers. So do know that you can customize these reporting periods, again, very easily. Choose your reporting period and click Update Page. And then the last thing to mention is, as you've noticed, when we are in this all provider screen, we're seeing lots of numerical data because we're presenting lots of different metrics. But sometimes it's better to share metrics, one metric at a time. And so you can also get to a display for a specific metric, choose the label of the column. And so, of course, NTSV cesarean sections are one of the more popular measures right now, since that's what we're actively working on. So just click on that column header label, and that will present you with a graph showing variation across your hospital for your providers on that particular metric. And once again, on the screen, you have all of the same options where you can use the drop-down menu to blind the results. You can choose your own reporting period with the start date and the duration, and you can set benchmarks if you like for your own hospital. And just always make sure to press that go button after you've changed any of the selection criteria. Okay. Just to reiterate, so where's this provider data coming from? For hospitals that participate in the Maternal Data Center from California, it is based on the birth certificate data, and specifically there is a field on the birth certificate for the license number of the delivering provider. And again, we found that to be highly, highly accurate. With the exception of sometimes some very small minor issues with typos that you can clean up in the Maternal Data Center. If you happen to be a Washington or Oregon participating hospital, then the delivering provider is coming through your maternal clinical file when your data folks upload that to the MDC. And do know that these provider data can be edited in the Maternal Data Center. And once again, the MDC team is happy to walk you through that if you have any questions at all. Okay? If you do need help, here's how to get in touch with us. There is a top black bar that is going to be on every single screen in the Maternal Data Center. You're going to want to click on the support link right there. That takes you to our support section, where you will find a section called Provider Level Reports, and there is a user guide for navigating the provider level report that goes through everything I just talked about today. So feel free to go access that document, or if you'd like some individual help, don't hesitate to contact us. Just click this button, Contact CMDC Support, or you can email us directly at at cmqcc.org. Both of those take you to our help desk, where the MDC team is happy to help you. And then last, let me just mention that we do have some upcoming refresher training sessions where we'll be able to go into this in a little bit more detail. So for California hospitals, we'll have a training session on October 19th. Just in terms of how do you navigate around the Maternal Data Center reports, both the hospital level reports and the provider level reports. And then we're going to follow that up on November the 9th with a section for the data geeks among us, which is the nitty-gritty of how to make data submissions, perform audits, and conduct a data quality check. So we're going to be getting into the real nitty-gritty with that second refresher training session. And if you're in Oregon or Wishaw Hospital, then the dates for those refresher trainings will be October 26th and November 16th. So that's it for me, and I'm happy to take questions, as I know Christa, Elliott, and the rest of the panel are.
Thank you so much, Anne, and thank you to Christa and Elliott, and thank you to our panelists for all the good feedback that you gave everyone attending on the call. At this point in time, I don't see any questions, so I'm going to just encourage anybody, if you have a question, you want to type it into the chat box or the Q&A box so we can address it for a few minutes. And while people are doing that, I'll just let you know that the meeting has been recorded, and the recording link will be posted on the CMQCC YouTube page, along with the slides that will be available on one of our platforms. We will let you know. So we wanted to thank everyone for being with us today, and if there's any questions, we'll be glad to take them at this time. So there is one question. How do you convince your MDs to unblind data? We cannot get past this barrier. Anybody want to address that?
This is Gail at San Ramon, and I thought it was going to be much more difficult than it was. Have you actually brought it to their department level meeting with them? Because that was where we actually changed their mind. We had a couple of wafflers, one hard no, and the other people were like, it's okay by me. So I think there has to be trust in the department that it's not going to go running around the hospital or whatever, that they're working on something so that we can all improve.
The department chair has actually said no.
Oh, well, I would, if the department chair is saying no, it's probably a work thing, you know, they've got too much on their plate. So maybe in that case, you would want to engage someone else, maybe like Christa said, parts of it. If you could do this part, you could do this part, you know, so that it's not overwhelming to any one person. Because I think that is a fear, is that it will become a big deal. But the unblinding of data, I would think the administrative team would also be able to help, because I know we have administrators that attend our monthly department meetings, and I think that, you know, they can broach it as a patient, you know, patient improvement, patient outcome improvement. And let's take a look. Nothing bad's going to happen. It doesn't change anybody's perception. What it does is say where we need to work on things, and maybe go have a cup of coffee with the person that's the lowest, see what they do.
Thank you.
I'm going to echo that for Gail, is that inviting people outside of your normal department meeting is very helpful for this. There are other parts of the hospital where the physicians have to answer for their specific data and metrics. So this is handled some other way in the hospital. So engaging your hospital-wide quality improvement team and your administration, if you have a department chair that's absolutely shutting this down, is really the only next place to go. First, have that cup of coffee, have that discussion, explain how instrumental this has been in decreasing rates and transparency in other hospitals throughout the collaborative. And if the coffee talk doesn't work, elicit some other avenue within your facility. It can't be the end of the road.
We have just a couple more questions, and I know we're almost at time. I'd like to go ahead and answer those two questions. One is, when physician champions were being courted, was there a time commitment up front? And if so, how long? And for the collaborative project, the time of the collaborative where we would have needed the physician champion was 18 months. But I don't know if anyone else wants to address it, if they approach it a different way with their physicians.
I mean, it's an 18-month project, but it's not like they're doing something every week. You know, we have a monthly call. We're working on things. Mainly, I found that the nursing staff provided a lot of the work behind the scenes, you know, the labor education, the peanut ball use, the, you know, changing the colors on the board, all those things were nursing. And so really the physicians get down to like a few really important messages that have to be, you know, sent. Unblinding the data, looking at inductions, why are we doing them, making sure they're ready for induction, cervical ripening, you know, that kind of thing. And then the dystocia checklist. I mean, those are the main three physician pieces. The rest is mainly, I think, a collaboration. And, you know, you kind of, you work with the physician, and it's not all on them. I think they think it's going to be all on them. You just have to allay that fear, because it's not.
Thank you.
So I think you can say somewhere in the order of a couple hours a month, but then there's lots of hallway conversations that are important. I think that's been raised, and those you don't really count, but I think you can get a lot done with 1 or 2 hours a month of good commitment plus hallway conversations. Now, obviously, more time might be of more benefit, but that would be what I would start people out on.
Okay, thank you. And the last question, it can be very time consuming to go through the records to identify the delivery providers. I wish this could be added to the birth certificate data. Anne, do you want to address that question?
Sure. I'm not sure if the question asker is from California.
Yes, they are.
Oh, okay. So the data in the maternal data center, we do use the birth certificate data, and it is the delivering provider is on the birth certificate data. Now, I don't know if perhaps the requesters at an academic medical center and maybe the birth clerks are putting resident down. I'm not quite sure what might be going on there, but it is California birth certificate. They are supposed to be putting the license number of the delivering provider on the birth certificate, and then that's what gets passed over to the maternal data center. So, so it should already be there for you if you're a maternal data center participant. Now, what a lot of hospitals have asked us about is the labor care provider, because particularly for those hospitals that have CNMs that are also performing deliveries, and they might be managing the labor, but then there may be cases where they have to pass off that, that patient to an OB, and then the OB gets credited with the delivery on the birth certificate. So we do have a way to submit labor care provider to the maternal data center. Labor care provider is unfortunately not on the birth certificate, so that is a supplemental data submission, and maybe that's what the question asker is getting at. But I'd be happy to talk with you offline as well and walk through that.
Thank you so much, Anne. Christa and Elliott, any parting comments for the group?
I've been so encouraged in this collaborative and our last with the participation of physicians, because that really does set the bar for success. And thank you for your comments today. I think they're helpful for engaging other physicians in this never-ending story of quality improvement in maternity care. Thank you.
Yes, thank you so much. Thank you for sharing.
Thank you, everyone. We appreciate your attendance today and all the good information shared. We'll be signing off. Take care. Have a nice afternoon.